pancreatic congenital lesions. This is a topic that we don't usually see very often in clinical practice, but it is quite important because these lesions can sometimes simulate disease, and these lesions can sometimes predispose to certain conditions, and then they're important in the context of special conditions like liver transplant and other similar conditions. So I'm going to just touch on the embryology briefly. In the 4th week of development, the ventral and the dorsal outpouchings develop. The ventral outpouching, also called the hepatic diverticulum, is what leads to development of the gallbladder, the extrahepatic bile ducts, the central intrahepatic bile ducts, the ventral portion of the pancreas and its ductal network. And the dorsal bud, which is also called the dorsal mesogastrium, contributes to the dorsal pancreas and its ductal system. So this is a diagrammatic view of the ventral bud and the dorsal bud. And that whole thing is the ventral bud, which forms the gallbladder, the extrahepatic and the main central intrahepatic bile ducts, as well as the dorsal portion of the pancreas. The ventral portion of the pancreas, and this is the dorsal portion of the pancreas, and this is the ventral duct. And then there is a clockwise rotation of the ventral bud around the caudal part of the foregut, and it fuses with this dorsal portion of the pancreas. And the ventral portion, which is the smaller one, is located posteriorly. And finally, these ducts join. So just to show you what the final picture looks like is this, where we have the entire pancreas. This is the body of the pancreas, which has the main pancreatic duct. The duct which continues in the more anterior portion of the pancreas, or the dorsal portion of the pancreas, is the duct of Santorini, and this is the duct of Wirsung, which goes through what we call the uncinate process. So the normal pancreatic ductal anatomy, the duct itself measures a maximum of 3.5 millimeters in the head, 2.5 in the body, and 1.5 in the tail. The duct of Wirsung unites with the common bile duct and drains into the major papilla, which is this one here. This is the major papilla. And the duct of Santorini, also called the accessory duct, drains into the minor papilla, which is, this is the minor papilla, this is Santorini. And this is a diagrammatic, this is a representation on MRCP of the same thing, where this is the main pancreatic duct. This is the duct of Santorini. This is the duct of Wirsung. This one is the common bile duct. Both of them having opening into the major papilla into the duodenum. This is the Santorini opening into the minor papilla, also into the duodenum. So the distal CBD and the duct of Wirsung traverse the sphincter of OD to enter the duodenum, which is here, right here. In 80 to 90%, that's majority of cases, the ducts unite within the sphincteric segment of the duodenum. That leads to about 1 to 1.5 centimeters length of muscle wrap. If they join high above the level of the sphincter, that allows reflux of pancreatic secretions into the CBD and can predispose to choledochal cysts. This is a normal appearance where, due to contraction of the sphincter, there is a narrow intersphincteric segment. So just shows that the duration, the distance of the duct that's within the region of the sphincter. And this is a diagrammatic representation of the sphincter. So you see that it actually encompasses the common portion of the ducts as well as the non-united portions. And this is the pancreatic duct, that's the CBD. Now, briefly on the anatomy of the biliary system, the intrahepatic biliary tree runs parallel to the portal venous supply of the liver. Consists of the right hepatic duct and the left hepatic duct. The right hepatic duct itself has the anterior and the posterior divisions. The posterior division drains segments 6 and 7, and the anterior division drains segments 5 and 8. All these 4 segments forming the right hepatic lobe. Now the anterior division of the right hepatic duct has a more vertical orientation, while the posterior division has a more horizontal course runs posterior to the anterior division and has a it has a medial approach, that is from the left side, fusing with the anterior duct to form the right hepatic duct. The left hepatic duct itself is formed just by segmental tributaries from segments 2, 3, and 4. This is easier seen on a diagram which I'll briefly show you. And the common hepatic duct is formed by fusion of the right hepatic duct, which is relatively short, with the left hepatic duct, which is relatively long. The duct that drains the caudate lobe, also called segment 1, joins the origin of either the right or the left hepatic duct. The cystic duct joins the common hepatic duct below the confluence of the right and the left hepatic duct, usually from the lateral side. Now, this entire thing is a normal anatomy, which is seen in just 58% of people. So this is a representation of the normal anatomy. This is right and this is left. So we said the left is longer, the right is shorter. This is the posterior, which is more horizontal and joins from the medial aspect. So it actually comes around like this. This is the anterior branch, which is more vertical in orientation. And this is multiple small branches. Now, in the pancreatic ductal anatomy, we can have several normal variants. 60% of people have a bifid configuration of the ducts of Wirsung and Santorini, like I described. In 30% of people, the duct of Santorini is rudimentary, and 1% have a dominant duct of Santorini, also called the dominant dorsal duct. Ansa pancreatica is a condition where there is a sigmoid curve in the duct of Santorini as it courses to the duct of Wirsung. There can be an appearance of narrowing in caliber at the knee of the main pancreatic duct, at the site of fusion of both the dorsal and ventral ducts. And to differentiate from a stricture, there is no upstream dilatation of the main pancreatic duct. One can also have duplication of the main pancreatic duct, but usually that just involves the duct in the body and rarely involves the dorsal or the ventral portions of the duct. So this is a dominant dorsal duct where the duct in Santorini is fairly prominent, and there is Santorini seal, which is a focal enlargement of the duct just before it opens into the duodenum. This is the sigmoid curve in the Santorini, duct of Santorini, as it courses towards the duct of Wirsung. This is the change in caliber at the level of the fusion of the main pancreatic duct and the duct of Wirsung without upstream dilatation to differentiate it from a stricture in which we would have the change in caliber but also dilatation of this entire portion of the duct. And this is duplication of the pancreatic duct in the tail of the pancreas. As far as the variants in biliary anatomy go, most of the variants are seen in the insertion of the posterior segment of the right hepatic duct. So in 13 to 19% of cases, the posterior segment of the right posterior duct drains into the left hepatic duct before joining the right anterior duct. In 12%, it empties into the right aspect of the duct and not the medial aspect, but really the lateral aspect of the duct. In 11%, you can have a triple confluence of both the anterior and posterior portions of the right duct as well as the left duct to form the common duct. And in a minority, like you can have an aberrant hepatic duct with direct drainage of the posterior segment of the right hepatic duct into the common hepatic duct. In 2%, you can have accessory ducts. Now, all this is very important in the case of liver transplant, where the donor is going to be donating the right lobe of the liver, or it's important for the surgeons for their planning prior to transplantation to see how the biliary confluence, the biliary anastomosis is going to work, the number of anastomoses they need to make, the caliber of the ducts that have to be anastomosed. There can be variants in the cystic duct anatomy as well. In 9%, you can have a low insertion of the cystic duct where the cystic duct fuses only with the distal third of the extrahepatic bile duct. In 10 to 17%, you can have medial insertion where it drains to the left side of the common hepatic duct. And in up to 25%, you can have a parallel course of the cystic duct with the common hepatic duct. So it's closely adherent to the common hepatic duct, at least for 2 centimeters. This particular variant is important because there's a high risk of injury to the common hepatic duct at the time of laparoscopic cholecystectomy. Now, this is a example of the posterior branch of the right hepatic duct draining into the left hepatic duct here. This is a cystic duct showing a medial and low insertion into the common hepatic duct. Touching on anomalous pancreatico-biliary junction. This is when there's fusion of the pancreatic duct and the common bile duct outside the duodenal wall. So the common channel is longer than 15 millimeters. This predisposes to reflux of pancreatic secretions into the biliary system as well as bile into the pancreatic duct, and it can lead to formation of choledochal cyst, choledochal web, pancreatitis, and over a period of time it can predispose to cholangiocarcinoma, which is why surgical treatment is sometimes suggested before these complications set in. So this is a diagrammatic picture where there is a long common channel more than 1.5 centimeters, and the sphincter of Ori does not reach the confluence of ducts. So therefore there can be a reflux in either way. Here there's a long common channel, and there is a web in the common hepatic duct, common bile duct. The other condition to cover is pancreatic divisum. This is the most common congenital anomaly of the pancreatic ductal system, seen in 4 to 10% of the population, where the ventral and the dorsal ducts of the pancreas do not fuse. So the majority of the gland empties into the minor papilla through the duct of Santorini, because the duct coming in from the main pancreatic duct does not fuse with the duct of Versa. And this can sometimes be seen with a Santorini seal. They can either be asymptomatic or present with chronic abdominal pain and idiopathic pancreatitis. When an ERCP is done, if the major papilla is cannulated, then only the ventral duct opacifies. On MRCP, one can see non-communication of the dorsal and the ventral ducts with independent drainage sites. The dominant dorsal duct is larger in caliber. The ventral duct is short, narrow, tree-like, or atretic. And a good diagnostic study is MRCP with secretin to enhance the appearance of the ducts. If the pancreatic duct is seen, then CT can be useful in its diagnosis. And that's an example where the main pancreatic duct continues on to the duct of Santorini. This is the duct of Versang and does not communicate. This is an axial CT picture of the same thing. That's the pancreas. This is the superior mesenteric vein, superior mesenteric artery. That's the duodenum. This is the duct of Santorini, which is pretty prominent. This is the duct of Versang. They don't join. This would be a dominant dorsal duct or a pancreatic divisum. Annular pancreas. This is when there is incomplete rotation of the ventral portion of the pancreas, and therefore a segment of the pancreas encircles the duodenum. This can be seen in 1 in 2,000 of the population. It can either be isolated or associated with other congenital anomalies. In neonates, these patients can present with GI or bile duct obstruction or with pancreatitis, and adults can present with peptic ulcer disease, duodenal obstruction, or pancreatitis. This is an MRI T2 weighted image of the duodenum and showing the pancreas that encircles it. This is an MRCP showing the same thing where the duct encircles, and you can see that this is the CBD. This is a choledochal cyst is a group of conditions which are due to a rare congenital biliary tract anomaly. There are several theories regarding its origin, and the commonest one is that it's due to a long common channel or distal obstruction. Usually these patients present in childhood. 20% of them present as adults. There's a female predilection of 4 to 1. The classic triad, which is only seen in minority of patients, is abdominal pain, a mass in the right upper quadrant, and jaundice. And it basically presents with dilatation of a portion or all of the extrahepatic and the intrahepatic bile ducts. There are various classifications. There is, several types of choledochal cysts. Type 1 is confined to the extrahepatic bile duct, in which you can have several subtypes. And this is, again, it results from a long ectatic common channel. This is the picture of it, where you have this. And this is an example of it. Type 2 is a diverticulum of the extrahepatic bile duct, seen here. And that's the picture here on ERCP. Type 3, also called a choledochal seal, is ectasia of the intramural portion of a segment of the CBD, leading to focal dilatation of the intraduodenal segment of the distal CBD. These patients present with intermittent colic, jaundice, and pancreatitis. And this is a diagrammatic representation of type 3 or choledochal seal, also seen here. Type 4 is multiple. Within it, there's 4A and 4B. So 4A, in which the cysts involve both extra and intrahepatic bile ducts, and 4B, in which the cysts involve only the extrahepatic bile duct with multiple saccular dilatations. So this is the intrahepatic and the extrahepatic choledochal cyst. And that's an example of it, the intrahepatic cyst and the extrahepatic cyst. And type 5, which is also known as Caroli's disease, it is a rare condition of congenital cystic dilatation of the intrahepatic bile ducts. It's autosomal recessive. It results from a varying degree of destructive inflammation and segmental dilatation of the ducts. Within this itself, you can have large duct and small duct involvement. Involvement of the larger intrahepatic ducts leads to Caroli's disease. The involvement of smaller interlobular ducts results in congenital hepatic fibrosis. Caroli syndrome is a combination of both congenital hepatic fibrosis and Caroli disease. These patients present with recurrent bouts of cholangitis due to stasis of the bile, recurrent attacks of right upper quadrant pain, fever, and rarely with jaundice. On imaging, there is intrahepatic saccular or fusiform dilated cystic structures that communicate with the biliary tree. The classical sign is central dot sign, which is a tiny dot with contrast enhancement due to the enhancing portal branch within a dilated intrahepatic bile duct. They can have intraluminal calculi within the biliary tree. Associated findings can be choledochal cyst, cholangiocarcinoma, and renal cystic disease. And that's a diagrammatic representation of the intrahepatic cyst or Caroli disease. That's an ERCP of the same thing, the CBD, intrahepatic bile ducts, and these are the cystic dilatations within it. That's a CT scan showing the central dot sign here. So you see the dilated duct tree, but you see the cystic areas, and you see the central dot sign, which is the portal venous branch. I'm going to now. So this is the dilated extrahepatic bile duct in type 1 choledochal cyst. Just 1 second. I'm sorry, I'm not able to hear you.
Hello?
Yes.
The right posterior hepatic duct is draining directly to the left hepatic duct.
Absolutely, and this is a very common anomaly, and it is important for the surgeon so that they know that they have two sets of anastomoses here and that the ducts are narrow in caliber. There is just waiting for my desktop to respond to me. Just give me 1 second. Okay. And these are the same thing. It's more difficult to see. These studies are pretty challenging to do. MRCP can show, but sometimes they don't have the degree of resolution that one can get. So a commonly used study is a CT cholangiogram, where the cholangiographic substance is injected intravenously and the patients wait for 2 hours, and then they are scanned again. And this is a ERCP of the same patient, confirming that's actually a T2. Okay. I don't know why my desktop's taking longer to respond to the next slide. Okay. I'm going to show you a couple of pictures. Tell me what you think of these. This particular case.
No impression of the cystic
One,
duct.
two. I'm sorry.
No impression of the cystic duct.
Actually, this is a better picture. Trifurcation. That is right. That is trifurcation. Yes. The same thing here. Trifurcation. Okay. This is a T2 plan.
Caroli species, right?
Yes. And the key thing to note is that the extrahepatic bile duct is normal. Now that's an MRCP post contrast. I'm sorry, MRI post contrast image showing the central dot sign. Okay, sorry, I gave out the diagnosis. Does everyone see that? So this is actually okay. This is the main pancreatic duct, and it's actually crossing the CBD, and this is the duct of Santorini. So this is that's the same thing here. See that? And this is the duct of Wirsung. So what would this be? Pancreatic divisum. So this is a common thing to see on MRCPs, because MRCPs we get these coronal pictures, and in the normal configuration we want the duct to go, the main pancreatic duct to come here, and then you want it to continue down so that both of them join. What just happened there? Sorry about that. You want them to continue so both of them join right here, which would be the duct of Wirsung, or the major papilla right here. But the fact that it goes across this is when one thinks of pancreatic divisum. Also, if you look at the axial images, when you see the duct going anteriorly, that is the duct of Santorini. The duct that goes posteriorly is the duct of Wirsung. So both, they're separate cases, but they both show the same thing, which is pancreatic divisum. So it's not necessary to be able to identify separately the Wirsung, see that it doesn't join. The fact that the duct crosses or cuts across the distal CBD itself is the clue for these cases. That's it.